In a nation where health innovation should be our priority, millions of men are silently suffering from a condition that's more than just an inconvenience. It's a quality of life crisis. At age 60, half of all men will experience an enlarged prostate. By 85, that number skyrockets to 90%. Yet, despite these staggering statistics, our healthcare system continues to fail those who need help most. Today, on the Heart of Innovation, we're going to dive deep into a groundbreaking solution that could change everything: prostate artery embolization, or PAE. We're pulling back the curtain on a hidden battle, though, where insurance companies are blocking access to innovative treatments such as this one, forcing patients into more invasive procedures with longer recovery times. So join us as we uncover what is an enlarged prostate, who does it impact, what causes it, what are the symptoms that patients are enduring, all treatment options, including the revolutionary PAE treatment, with expert insights from Dr. Misha Ginsburg and Dr. Osman Ahmed. We'll expose the truth about a medical system that too often chooses profit over patient care. This isn't just a medical discussion. This is a true fight for men's health, dignity, and quality of life. So stay tuned, and we're going to kick off this powerful conversation in a moment. But first, I want to take a deep breath, wade into the show on a lighter note with a big welcome to my co-host, Dr. John Phillips, and wish his lovely bride, Carolyn, a very, very, very happy birthday today.
Yes.
Happy birthday to ya. Happy birthday to ya. Happy birthday. We appreciate you in our life right now. So happy birthday to ya.
I love it.
All right,
A
man.
big
That's
round of
awesome.
applause for Colin, and
Good
a
job,
thank you for
Colin.
his little
That's
Stevie Wonder.
fantastic. Yeah,
And
no,
it's his last day, so
is it real?
I
Okay.
had to give him the platform.
That's awesome. Yeah, he you know what, Colin, thank you. Kimberly, thank you. Yeah, it's Carolyn's birthday today, so just chilling out. Actually have a little father-daughter dance this evening. So
Yes.
yeah, indeed. It's all good. We went out to dinner last night. Just be thankful for another year around the moon, or excuse me, the sun, as they say, another trip around the sun. So yeah, it's good stuff. Thanks for giving her a happy birthday. I'm
Yeah, make sure she
interested.
does a little playback.
I certainly will. I'm interested about having this conversation with our esteemed guests because this is something I don't know very much about BPH, but interestingly enough, I am on a DSM, so a safety monitoring committee for a balloon. I'll probably get this wrong, but there's a medicated balloon, typically or similar to a balloon that we use in the legs for PAD that they're looking at using that same medication to reduce the enlargement of the prostate and inflating that balloon up and trying to shrink it. So this is kind of interesting to me. I don't know a lot about it, but I'm excited for the conversation. So we should probably jump in here pretty soon, huh?
I think so. Let's kick it off with a moment of inspiration.
Dr. John Phillips' spectacular vascular moment of inspiration.
I was looking at kind of men's health. Obviously, is something that I'm interested in, as we've talked about with the Game Day Men's Health Clinic that I'm a part of. But I looked up famous men with prostate cancer, right? And I know this is BPH, but so prostate cancer. So Nelson Mandela was diagnosed with prostate cancer in 2001. Colin Powell, Robert De Niro, actually Ben Stiller also has prostate cancer. So I wanted a nice short inspirational quote from Nelson Mandela. And I thought this one was kind of interesting because, that man was resilient as all get out and, determined, etc. And so he's quoted as saying, it always seems impossible until it's done." So, I like that because it sounds like this is a new, the prostate artery embolization. Sounds pretty interesting to me. Perhaps people thought that was impossible, but obviously we're working on it. So, yeah, it's always seems impossible until it's done.
It does. It does. I'm curious, Dr. Osman Ahmed and Dr. Michael Misha Ginsburg, would love for you to weigh in.
I think that you mentioned it's new. It's actually not, the procedure itself is not that new. It's been there for a couple of decades. Initially developed in Portugal and Brazil, actually, and then ultimately brought to the United States. And at this point in time, this procedure, which is a minimally invasive procedure to treat patients with enlarged prostate. And I guess to start with, it's great to sort of introduce the topic and kind of quickly describe what it is, right? So just the prostate is a gland that sits there in a male reproductive system and is in a pathway of urine from the bladder to outside. So if the prostate enlarges, it can press on the bladder and ultimately the urethra and block flow of urine. And ultimately that results in what we call in medical terms, lower urinary tract symptoms, okay? And those lower urinary tract symptoms are things like frequent urination, difficulty initiating urination, waking up multiple times at night, like you mentioned, which Kym, you mentioned how impactful it can be on the quality of life of patients. So ultimately things that contribute to inability to fully empty their bladder, right? And as you correctly mentioned, and I'm glad you mentioned that, most men actually suffer in silence. And the frequency of this condition is overwhelming, right? As you said, more than 50% of men after the age of 50 suffer from this. So historically, once patients experience kind of more moderate to severe symptoms of the lower urinary tract symptoms, their options were surgery, right? And surgery, it involves instrumentation through the penis to get to the bladder and do a surgical resection to clear the passageways, right? Basically plumbing. Most men didn't want to buy this procedure. This is not something you want. And the reason you don't want that is because that instrumentation carries a risk, and real risk. And the risk of 10% of impotence, right? Incontinence, and also retrograde ejaculation.
Pretty significant risks. And coming up right here on the Heart of Innovation, you don't want to miss the alternative approach to these very risky complications. So stay with us, don't go away.
We had a case where I'm going to show it because I have it at my fingertips, because this was a patient that was told certainly no option. This was a patient who has had multiple operations, as you can see here. And if you look at the wounds on the toes, they're pretty significant and not a lot of options for intervention. So this patient would have been condemned to an above the knee amputation. And because of the ultrasound, we know he has the worst type of flow to his toes, but he also has a blockage up here in his profunda artery. And so what we ended up doing with Dr. Constantino is we did a radial access, Kym. So we entered in the artery in his wrist and did simple ballooning of that blockage. And look at the blood flow in the foot went from very bad to pretty good, all with the simple balloon. And this was just over time, he healed. And at 1 month or 1 year, he's completely healed. And he has a lot of collaterals supplying that foot. But because of that simple balloon, we were able to make a massive impact and avoid amputation. So the lesson learned here is I think we still have a lot more to learn about pedal duplex and P.A.D, but so far it's really proving to be a valuable test in these complex patients.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thank you for joining us. We are going to jump into this topic of benign prostate hyperplasia, hyperplasia or hypertrophy, BPH, which, again, as we mentioned, affects a lot of males over the age of 60. And it's kind of a nuisance, as I understand it. But so the two physicians that are joining us, doctors Ahmed and Ginsburg, during the break, they basically have gone through residency together, fellowship. They live close to each other. I mean, so now the two of you, both of you do interventional radiology. How did you guys, Oz, you can go first if you like, how did you get into embolizing, which means basically closing off the blood flow to the prostate in an attempt to treat BPH?
Yeah, great question, John. Thank you. And thank you for having me on as well. So, I think as Misha has sort of eloquently stated, I think, there PAE or prostate artery embolization has actually been around for quite some time. And it was actually first sort of described when we were both in training together when we were residents. So it was sort of a hot new thing back then, which was, I hate to age myself, but, about 15 years ago or so. So, but like all things in interventional radiology, we do a lot of things that are a non-surgical alternative for people who are looking for sort of procedures that have less recovery time, less side effects, all those sorts of things. So for this prostate artery embolization, as Misha has mentioned, the traditional therapies are very undesirable for a lot of patients, and so there is a big need for a therapy like this. And so the nature of our specialty is to innovate and to sort of provide these solutions. And so that's what's really, I think, got us really excited about this and involved at a very early stage of our career.
I agree completely with us, and the question also is, how was it discovered, right? So our specialty and what embolization really is stopping blood flow somewhere, right? And so we are sort of the masters of stopping the bleeding anywhere in the body, right? So initially, the treatment for bleeding from either the prostate or the bladder, okay, was done by us. But that was when urology, or the doctors who take care of bleeding from the urologic system, cannot stop it with their surgical techniques. And so initially we were just stopping the bleeding from the prostate for purposes of stopping the bleeding. And we saw the side effect is shrinkage of the prostate, right? And ultimately, once we saw that men whose bleeding we stopped experience improved lower urinary tract symptoms, experience decreased BPH symptoms, then that's sort of kicked off the process of, let's see if it actually helps men. Okay, so just wanted to add that. And then ultimately it resulted in multiple studies, of over 20 prospective studies, 6 randomized control studies showing that it's effective and comparable in terms of its outcomes to the gold standard, which is TURP, or transurethral prostate resection. Sorry for the plug, but I just wanted to make sure people understand the background of that.
If we could take just a quick step back for our listeners. So the prostate is basically squeezing. It's getting so big, it's squeezing the urethra, which is allowing the urine to come out, right? So what is a normal prostate size? And people are probably thinking, are these guys crazy? Like, my prostate needs blood flow, and now they're trying to shut the blood flow off. Like, what is that going to do to my prostate? What's that going to do to the important real estate, if you know what I mean, the important real estate that's down there?
So good question. I'll put my sort of answer out there, and then I'll let us add to that. I think that one of the reasons it's in the guidelines now, both European urologic guidelines as well as American Association guidelines for American Urology Association guidelines for 2 years, it's because it's not just effective, but it's safe. And it's much safer, actually, than the urologic alternatives. And in terms of blood supply to the prostate, what it ends up doing, and it's not unique to prostate specifically, is when we shut down the blood flow, the organ or area basically shrinks. So I would say normal prostate size is about 25 ml or 30 ml, which is basically a size maybe of a walnut, okay, or maybe a little bit bigger than that, and then it can grow to sizes of over 100 milligram, and sometimes even bigger than that. And so, it's a safe procedure with decades of data that's showing not just midterm and short-term data, but its efficacy is also proven in a long-term aspect, and it compares well with other procedures. So, sorry,
Yeah.
go ahead.
No, that's great. I'll sort of also answer John's question by giving a very sort of very brief or sort of simple explanation of what's happening with an enlarged prostate. So benign prostatic hypertrophy. So benign refers to a non-cancerous growth. So it grows like a tumor, but it's not a cancer. It can't spread, it doesn't kill you. So as Misha just said, the prostate enlarges significantly. And there's different parts of the prostate. You have basically your outer zone. That's actually where cancer forms. And then you have sort of the inner, what's called the transition zone, which is the sort of inner part that actually constricts the urethra, restricts the urine flow, and causes a lot of the symptoms that we've talked about. So that's where BPH actually acts. And that's where, because it's growing like a tumor or tumor-like growth, it's getting a bunch of blood flow you're not supposed to have, because it's feeding this tissue. And so those are the arteries we're targeting. We're targeting the arteries that are not meant to be there, that are contributing to the growth, to kind of shrink this abnormal tissue and relieve the compression on the urethra and sort of facilitate normal, basically, function of the prostate in sort of normal function of the bladder and urethra. So we're trying to get things back to normal. We're not trying to make things anything different than normal. If that
What do you
makes
guys know
sense.
about paclitaxel balloons inflate, into the urethra for reduction of the prostate size?
I have not
I know
heard
that's
that.
clinically being trial, and
Yeah,
because I'm on a
there's a,
safety board for it.
there's a lot of what are known as MISS, like minimally invasive surgical therapies for
Mhm.
BPH. It does make a ton of sense to use paclitaxel, obviously, applying it from the P.A.D. or even the chemo world. But I don't know much about its efficacy, and I think we can obviously talk about this with PAE. Like, it's obviously the only procedure you don't go through the penis. So that's where we get
Right.
a lot of, obviously, patients interested by that. And the rate of sexual dysfunction is pretty much zero as well.
One thing to add, paclitaxel, one of its properties, it's antifibrotic property. And, when we're talking about strictures, it certainly can be effective. But in terms of mechanical obstruction due to size of the prostate pressing on the urethra, it's a slightly different process, right? It's more of like a compression due to enlargement. And, I know that for strictures, things like drug-coated balloons can be effective. I'm not certain this, is going to play out in the world of BPH. Could be wrong, obviously.
Yeah. I'm involved because there's the work that I do in PAD. But yeah, I haven't seen the data yet, but it seems interesting. So you guys are targeting. So are you targeting branches of what is it? What's the artery? It's not the pudendal, is it?
It's prostate
prostate.
artery.
The prostate. So you're targeting specific arteries off the prostate, or I'm sorry, specific branches off the prostate artery that are just like collateral, or maybe not collaterals, but just you can tell like they're not supposed to be there in quotes, or I guess I'm just curious, like how do you target the brand, what you want?
Yeah, it's a good question. So basically, you have capsular branches, and then you'll have branches that basically go to the gland itself or the central aspect of it. So we pretty much go to those, which is the majority of the branches. It's this is the male equivalent of like uterine fibroids, basically. So you go to the hypervascular tissue.
So okay, and now what
So
do you
you have
guys
a
use? Glue? What are you using? Glue, or how are you embolizing it? Coils?
So there's different techniques. A more conventional technique is basically using kind of sand-like particles, which are beads, for the prostate. Some people use some other things as well, but the majority of data comes from particle embolization.
Okay.
And in terms of the arteries, as Oz said, you have basically prostate typically gets supplied by two prosthetic arteries, one on each side, and we go and target those prosthetic arteries to decrease the vascularity of the prostate and ultimately lead to its shrinkage.
Well, coming up right here on the Heart of Innovation, we'll have more with Dr. Osman Ahmed and Dr. Misha Ginsburg. And we're going to be talking more about the medical insurance company resistance to doing these minimally invasive procedures. So don't go away.
So let me tell you a little story. 2 years ago, when I had a bypass operation in my right leg and in my groin, and the one on my right leg below the knee to above the knee did not work. And when my wife was in a waiting room, talked to the surgeon after the surgery, she said he was telling her about the operation, and she said, "What's next?" He said, "Amputation of my right leg." When I went to bed at night, I almost cried myself to sleep because I was going to lose a leg. And now things are a little different. Last year when we came to Disney, I was walking about 100 to 200 feet in a wheelchair 80 and 90% of the time. I'm sorry, 2 years ago that was. When I got back after vacation, I ran into you, Kym, or your website, and I started the walking program. Well, today is our 5th day here, and we average between a low of 6 to a high of 10 miles each day. And the other thing we're doing, we're staying on the 5th floor, and naturally there's elevators, but twice a day, my wife and I are taking the steps, walking up the steps. And I can feel that. I mean, it kicks my ass, but excuse me, but, we can make it. But I'm not saying it was painless, but it was bearable, It's unbelievable, just the progress we made. And sometimes I get some pains worse than others. I think, maybe I'll try to go in and clear some of this out, but I don't think it's necessary yet.
Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. So just a quick recap, right? I think we've established that BPH is prevalent. It's problematic for males. You two have discussed this treatment, embolization, which appears to be safe and effective. So two questions, and Kym alluded to this before. It sounds as though there's some reticence from the insurance companies to actually approve this. But before we dive into that, how many of these procedures are being done on a yearly basis as opposed to like TURPs or some of the other more conventional ways to treat BPH?
I don't know the exact numbers, but I would say that the utilization of this procedure is increasing quite dramatically. And the adoption both in our world as well as, in the world of urology, right? Like you now have groups of urologists and interventional radiologists combining together to provide those services to their patients. So, it's an easy sell to patient because, they know that their sexual performance is not going to be affected. If anything, there's some studies that actually show that there might be some improvement. So, this is a minimally invasive outpatient procedure in and out, right? There are some, Kym was asking about earlier, or maybe during the break, about the post-procedure type of symptoms. And we were sort of talking about uterine fibroid embolization. And as As mentioned, the recovery is relatively very smooth. I mean, they go home 1 to 2 hours after the procedure is done. There are some sort of, again, lower urinary tract symptoms like urgency and frequency that we control with some antispasm medications, but ultimately it's completely painless. Okay, they don't need to have a Foley catheter, which is a big thing for some men, and they start getting improvement in their symptoms within 1 to 2 weeks. They started seeing improvement.
So what are the indications for this procedure versus, let's say, a doctor saying, you know what, this procedure, this minimally invasive approach is not right for you. You do need to have a surgical procedure. Are there any indications for one versus the other?
Yeah,
Go
no,
ahead.
I'm happy to answer that. So, I think just like in a lot of disease states, you want to sort of escalate what you do. So, I think Misha sort of alluded to this at the beginning, which is, historically you used to say, okay, well, you have an enlarged prostate, you're having these symptoms, they're severe enough that they're causing you problems. So we first try medications, and typically the sort of most common medication that we give is called an alpha blocker, which is also known as Flomax, is probably the most commonly sort of recognized medication. When that doesn't work, sometimes you can try, additional medications, but then you sort of historically we've jumped to surgery, and again we've talked about why surgery is sort of may be very aggressive and have some untoward complications that patients don't want to sort of incur that risk. So then they sort of suffer in silence because they don't really have any other great options. And so what's evolved are what are known as minimally invasive surgical therapies, and PAE, or prostate artery embolization, falls under that umbrella of MIST therapies, minimally invasive surgical therapies. So now there are some urologic procedures that are minimally invasive, but they all do go through the penis. And there's PAE, which doesn't, and has sort of some of the reduced or almost no side effects sexually. So that's where we sort of work in terms of our sweet spot is for patients who are not getting good relief from the medications and either don't want surgery for the things that we've just talked about, and are looking for continued relief from their symptoms.
Walk us through a patient kind of comes to see so maybe their PCP referred them to a urologist for BPH, and the urologist said, okay, let's try one of these MIST procedures, so prostate artery embolization. So they come and see you guys, you assess them, okay, you'd be a candidate, and we alluded to this before, and I think we should start talking about it. It sounds as though there's difficulty getting this procedure or some of these procedures approved by insurance companies. So tell us a little bit about that process and why you guys think that that's the case.
I'm going to try to tackle this because this is kind of the article that we've talked about and that sort of prompted, I think, this whole conversation in the first place. And that's insurance companies don't always update their policies. Okay, and while there are some procedures out there that could be in trials without mature data, still kind of being investigated. Once procedures end up within the guidelines, after they've been shown to be effective and safe, not approving those procedures is just mind-boggling, right? Like what this is basically preventing necessary optimized care to patients, and this is what insurance companies should be doing, but they basically do not update their guidelines. And so you're facing with middlemen companies that are there just to sort of create a process of denial of different type of care, and you're trying to advocate for your patient with sometimes requiring peer-to-peer, basically trying to get this procedure approved, and that peer-to-peer who is really not your peer ends up saying to you that's not within the insurance policy to cover this procedure because it's considered sort of investigational, which is mind-boggling.
So I'm on the other end. I work for an insurance company. I'll play devil's advocate.
Mm-hmm.
Maybe I'm a pediatrician, whatever, but I see a list of approved procedures, and I go through my list, I'm assuming, and I don't see your procedure on there. So you can't really fault me. I'm just kind of like the lady that works at Delta that's trying to help you find your luggage. I didn't lose your luggage.
Mm-hmm.
But so the issue then becomes, who do you have to change? You have to go through your societies to then kind of get the insurance companies to buy into this, or how do you enact change, I guess, in this? Or maybe I'm interpreting it wrong.
I think that's the missing piece. There is no mechanism to sort of, like, I think what Misha's saying, to update these policies, or we don't know how that's done, because you would assume that once something enters treatment guidelines, has been validated through multiple randomized controlled trials, and is, widely accepted by all specialties as an acceptable treatment, why is a third party sort of saying no to that? And that's what I think it leaves us frustrated, because you do these peer-to-peers, and these people they literally will say, we agree with you that this procedure is indicated, but I don't have the ability to change it. And it's like, okay, well, why am I talking to you?
Exactly. Yeah, no. I mean, it's not their fault. There's nothing they can do.
Right. It's like, but that's the real heart of the problem, is there's no mechanism to change that, or no clearly defined mechanism,
So
the whole idea of peer-to-peer is like not a real thing, I think. Sorry, Misha, go ahead.
No. I mean, I think, even like that example that, I brought up, and I sort of posted something, I think, on Twitter that sort of ended up in an article. I think that, ultimately, when I went back to Cigna policy that is published online, you can access, they don't even mention P.A.D. at this point in time. Maybe they took it away. Maybe they're looking into that. But again, this is something that's been introduced into the guidelines a year and a half ago. And then, but you still have the middleman, which is Evicor. It's the same company that does that insurance denials for Cigna as well as United. And then to them, it's still investigational. And this company, it's it's a business, really a business to make money, greedy business, that for every $3 they save the insurance company, they make $1. They make $1, right? So while they're claiming that this is like providing sort of intelligent care, in reality, they're in the business of making money, and denying claims is how they make money, right? That's all. And so, and then they have this process, which is basically like for us as physicians, and what leads to burnout is basically we are in a hamster wheel, right? They just like put us through those red tape and bureaucracy to basically deny us and say, I'm sorry, Cigna, Cigna hasn't considered its investigation, and go to Cigna, and they are looking into that. But ultimately, you have a patient you're dealing with that has a problem, and you want to solve that problem, and that problem has a solution, and it's within the guidelines, and you can't do anything about it.
What's amazing to me is there are 3 class action lawsuits against Cigna, Humana, and United Healthcare, with the software showing a 90% error rate, the software being used, the algorithm being used for these denials, 90% error rate in these denials, which is incredible to me. And yet, I don't see anyone acting. I don't see any of the policies being changed. Are they afraid if they do, that they're admitting wrongdoing and they're going to lose these class action lawsuits, which I think they're going to lose anyway. But I think that we need to push harder on Capitol Hill to create the change that we want to see, because it's got to come from the top, or else it's not going to come at all. If we don't have the changes, happening right there with Congress, we're not going to see anything. I call for an executive order on this one, because so many people are suffering out there because of these delays and denials. And coming up right here on the Heart of Innovation, we'll dive deeper into the incredible number of insurance denials, not just with P.A.D., but across the board for minimally invasive procedures that are costing both life and limb. So stay with us on the Heart of Innovation. Don't go away.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just step
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here. Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should, because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for. Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. closed minds are what we have to get rid of.
Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. So we pulled the pin on the grenade regarding insurance denial, but I mean, the person that you're talking to, that's your quote peer, after you've had the procedure denied, probably again is following an algorithm. They're not going to be able to change the fact that they can't approve this procedure for you, because whether it's still investigational or the insurance company hasn't upgraded their policies or updated their policies, whatever. So what do you two gentlemen propose? Like, how are you going to enact change? Is this a grassroots effort? Are we talking to our local state representatives? Like, what are you guys' thoughts?
I mean, I think we are doing it right now, right? We're talking about it, right? Ultimately, we shouldn't be having difficulty approving things that are within the guidelines, right? So this is an issue of insurance companies that are not, maybe intentionally or maybe for bureaucratic reasons, are not updating their policies. And by that, they're hurting their patients and their insured population, right, ultimately. And, I think Oz alluded to that. Some of those treatments are more cost effective. Actually, prostate artery embolization is a more cost effective treatment in the long run. So, some of it is just a lack of insight. So, we have to talk about it. We have to bring it up. We have to discuss it with patient groups on social media, because we don't have other solutions. Yes, hopefully the societies will kick in and start arguing on our behalf. We are waiting for this, but
yeah, I don't understand why they're waiting. I mean, I'm curious. The real Dr. Oz over here. What do you think? I think personally, we should get rid of all pre-authorizations, any second guessing of the doctors that are out there. I know from personal experience, there are doctors that are, putting in those pre-authorizations, doing unnecessary procedures, not following guidelines to do conservative therapy first. I know there are doctors out there across the board that aren't doing the right thing, but I don't think that the doctors that are doing the right thing, which is the majority of doctors out there, I don't think that they should be punished. I don't think they should be second guessed. I think that it needs to come down to, the doctors that the insurance companies don't believe are doing the right thing. You know what? Then don't contract with them. But don't leave the patients to suffer for weeks and weeks and weeks on end, waiting for something to be done to improve their symptoms, only to find out that they can't have the procedure. It's just this false hope that they're giving them. So I would say, what do you think, Dr. Oz? Get rid of these pre-authorizations, put the power of healthcare back in the hands of doctors, and save the system $7.2 billion, which is costing these providers to appeal these claims, appeal these denials.
You're absolutely right. I mean, I think you have said that perfectly, in that the minority of people are punishing the majority of us physicians. Obviously every profession, everywhere, you always have some bad actors, but we shouldn't transfer that punishment to our patients. And I think, as Misha has said, a procedure that's in treatment guidelines, there's absolutely zero reason that it should be denied. As long as you are following those treatment guidelines in terms of, the indications for using that treatment, there should be no pre-authorization. It just leads to unnecessary delay of care and potentially, loss. It could lead to not only morbidity, but also mortality. I mean, patients may die. We talked about critical limb ischemia as well. These are potentially life-threatening diseases. Now, prostate artery embolization is not that specifically, but it does create a lot of problems for patients. And so, I think you have hit this on the head. I think that strategies like that, to kind of put the power back to physicians to allow us to do our jobs, treat our patients, and not have a middleman to sort of tell us what to do, is definitely one part of the solution. I do think that, going back to John's question, it's complex. I think the answer will come from many different things, whether that's, like what Misha said, us just speaking up, But that's just getting the ball started. But we need patients to hopefully speak on our behalf. We need, policymakers sort of helping us. We need societies, urological and interventional radiology to support us. And ultimately, we need the policymakers at the insurance companies also to basically listen to what we're saying. And so, yeah, I mean, I think these are I'm glad we're talking about these things, because this is what needs to be said.
Yeah, no,
Right.
I am too. But like at the end of the day, at least in my opinion, the 30,000-foot view, and we only have 2 minutes left. But the system is broken. It's too costly. It's too expensive. The insurance companies, you're beholden to them. They hold the purse strings basically. But I mean, again, playing devil's advocate, they're in it to make money. They're a business. It's a business, so they're going to probably have to parcel out whatever it is that they're going to offer. And I guess, and again, playing devil's advocate, some people are going to get it, some people aren't. That's just the way it is. I don't agree with it, but I mean, that's in 2025, I believe that's where we're at.
John, you mentioned something that I think is kind of very important. You can't blame the individual physician that's kind of peer-to-peer sitting there and saying, hey, this is a policy, it's not within the policy, I can't approve it, right? And I don't think of that physician as being greedy or wrong in any way. He's just positioned there by a company. Now, there's some people call AviCore evil core, right? Like if you go out there on X, you'll see a bunch of tweets when people say hashtag evil core, right? So it's not something that comes out from, me. There are multiple physicians that face denials on multiple claims and when they go through the process of trying to approve the indicated procedure for their patients, they're throwing through, again, hamster wheel of a doctor who sits there, not empowered. I have peer-to-peer conversation, and the doctor says, yeah, I agree with you, like us said, right? Like, I agree with you, I can't do anything. Well, why are we having this peer-to-peer? The whole idea of a peer-to-peer is that you have the ability to listen to the clinical judgment, understand patient-specific sort of condition and their specific problem, and then tailor it to that patient. Maybe if it's slightly outside of the norm. Again, this is not outside of the norm. This is a clinically indicated procedure that is done within the guidelines, right? But let's say this patient, I'm just going to give you an example, had a very large prostate, more than 100 grams, right? So something that is TURP is not an option. None of the other missed sort of minimally invasive urologic options are there besides one laser that maybe 3 hours drive away. And the only other procedure that is indicated is prostate artery embolization that is agnostic. Doesn't matter what size prostate it is. The bigger, the better. We'll get there, right? And this patient may actually be urocardiologist, right? Needs to continue their dual antiplatelet therapy because
I'm so sorry to interrupt, ladies and gentlemen, boys and girls. We have to go to commercial break. Keep tuning into AM 1220 KDOW right here with Kym McNicholas and Dr. John Phillips.
Your type of condition is called critical limb ischemia. It's the most advanced form of P.A.D. or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to P.A.D. and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with P.A.D.
And all I heard was, what are we doing here? Just cut it off. And I pulled the curtain back like, are you kidding me?
Do you really want to go through all that?
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always
get multiple opinions.
We do have options. We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Well, kids, the sun is setting on another fantastic show. Dr. Ginsburg, I'll let you finish your thoughts, and then we'll hand it over to Dr. Oz for some final thoughts as well.
So, so we were talking about basically physicians who are in a peer-to-peer process, not to be blamed for what really the goal of the company that is a middleman company, like we were talking about Evicor, or what some people in X call evil core, which is its main function is to deny claims, right? And so they create a whole process that is essentially outsourcing for big insurance companies the denial of claims without being able to get their finger or blaming finger on insurance companies. They're saying, okay, we are outsourcing this to this independent agency who is out there objectively looking at this approval process and looking at the guidelines. Nothing can be opposite of truth. This is misrepresentation, right? This is misrepresentation. Number one, this sort of secondary or in middleman company is there to make money, to deny claims. One, two, this is not real peer-to-peer process, right? And they are not providing up-to-date, based on guidelines care, or attempting to guide care based on guidelines, because they're not updating their guidelines. So it's not true. This is a situation we face as physicians, and ultimately our patients suffer because of that.
And final thoughts from Dr. Ahmed?
Yeah, no, I think all great points from everybody discussed today. I think the main takeaways are that the insurance processes really obviously lead to delayed care, and in a lot of cases, denied care, which is oftentimes inappropriately denied. And so I think what we've really touched upon is, I think whether you're a patient, you're a physician, or someone who's highly interested in this, it's going to take a lot of action for change, and I think these are sort of the first steps that we need to do to get there.
And with the Guardian reporting a 90% error rate in these algorithms being used, I mean, it's not a minority that are being denied or having their claims delayed, their procedures delayed because of these insurance companies.
So for every, I don't know, 5 you guys requests you put in, how many are you getting denied?
Well, I mean, I think this is denial. I actually probably had a couple of recent denials, because I started seeing some patients with Cigna insurance, and one of my partners had it denied, and so that's sort of like that sort of made me think about this, in terms of like raising our voice, starting to speak out. I haven't had denials of prostate artery embolization here more recently. As I don't know about you, but I just wanted to.
Yeah, it's the minority, thankfully, at least in my practice. What I think is is almost equally as painful, though, is they prolong the process, though. There's the pre-medical determination, all this stuff, which it literally takes weeks to months to get these patients, just that part approved, and then you schedule them, and obviously we're all in busy practices, so that also adds another month or two. So it's more the delay on my end than necessarily the full denial.
Sure. What's amazing to me is when you go out there on Twitter and you go out there X and LinkedIn and you see the hashtags for these insurance denials, it's real doctors that are showing so much compassion and empathy towards their patients. And literally, it just comes through that if these doctors, why would these doctors, if they didn't care so much, why would they be going public with this? Not for their own wallets. They're sharing real stories of suffering and they're being ignored at the highest ranks. And that's what's most disconcerting to me, that the pleas that I see from physicians such as yourselves are so heartfelt and heart-wrenching. But I can't believe that nothing has been done today.
I have
or
to believe,
yesterday.
though, like to some degree, that is the minority. I mean, to Oz's point, for me, it's just the road bumps that they put up, and it's just increases my level of frustration. I get the procedure approved, and we can get them expedited. The folks with claudication and BPH, okay, I mean, yeah, it's frustrating. I've not had a denial on anybody with anything life or limb threatening, and maybe that's just the region I'm in, but it's just the annoyance of it and to the hamster wheel thing. But at some point, it's so you got these peer-to-peers. We spend our lives in front of a computer looking at Epic charting. It's like all this stuff adds up, and after a while, you're just like, okay, you guys broke me. You guys broke me. Like, I'm done. I'm done.
That's
Uncle.
exactly what
Okay.
it is.
But that's the point, right? Like ultimately, I guess insurance companies kind of rely on that, like in a way, maybe indirectly, right? I mean, the unfortunate thing that most doctors give up.
Yeah.
I mean, we don't have enough studies, but it would be nice to look at that. Actually, it's how many of those denials end up of patients not receiving the care they need, right? Because ultimately, that's monumental, because it's hard to fight a system that has the infrastructure to deny claims, right? And we're talking about layers of administrators before the doctor who doesn't have the power to overturn the denial, and we're talking about money spent on both sides that is completely wasteful, right? Like we're wasting money to have conversations that are not productive and not contribute to any patient care. It's basically counterproductive and harmful.
We have a couple questions that just came in. Douglas.
I do have to get up quite a few times during the night to go to the bathroom, but I don't have issues going to the bathroom. I just have to get up a lot during the night and go to the bathroom. So I was wondering, because I have a bypass that's blocked. So I was wondering if there's any correlation between the P.A.D. issues and prostate issues.
The short answer is no. What P.A.D. does is makes our job a lot harder. So if you do, a lot of times we're often treating patients who have enlarged prostates who are older men, so they more often than not have some atherosclerosis. So it can make the procedure a little more challenging to go through the arteries. Historically, really, if you had really bad P.A.D. Where all the blood flow to your pelvis was blocked, you could get impotence. So we would see things like that, but there's no correlation with enlarged prostate specifically.
And I wanted to give both of y'all a shout out. Don't give up. Y'all are making a difference in what y'all are doing and how y'all bring this topic up. So don't give up as a patient. Don't give up, because we need you and we need your voice. So don't give up, okay? We're all standing with you.
Thank you.
Yeah, seriously. I just still can't understand why these procedures are being denied when it costs the system less. Is it the fact John says he doesn't have any problems with these pre-authorizations? He just gets her done. Who's having these problems and why? You both work in hospitals as well, and you're still having problems. Is it the department? Is it IR versus IC?
No, well, I think like when he mentioned that John gets things approved, and he mentioned about limb salvage and critical limb threatening ischemia, which we also treat those patients, and we don't typically, when if it's not collocation of the real limb threat, then obviously it's hard to deny those things. They've been established and they've been there for a long, long time. This is, a relatively newer thing, right? But it's in the guidelines, right? Like, so, and it has data to support it. So, we are just facing it now. These patients know that this option exists for them, right? That's why they choose this. They may be on the verge of going to full urinary retention, requiring a Foley catheter, or waking up 4 or 5 times at night, without quality sleep and multiple other issues. They may be incontinent, right? Like they could be, literally incontinent because they have something we call overflow incontinence. They're so difficult for them to urinate that eventually they have an accident. So these people are suffering, and they don't want to have potentially the side effects of that alternative urologic surgical procedure, or they're not surgical candidates. So one of the times we treat these patients are sometimes patients with urinary retention and chronic Foley catheters, right? Those people who have to walk around with Foley. So these people are being denied a treatment that exists in the guidelines, and because it's relatively new, the insurance companies didn't catch up to that on time, and they're denying the claims and denying those procedures while it's already been introduced in the guidelines, and patients are demanding those and asking for those.
Wow. And Kym from Canada is sharing a story here in the chat about her dad that in 2008 had prostate surgery, and they were told that they couldn't put him under and would keep him awake, but then they went to pick him up. Turns out that he did they tried to put him under, and he might have had an allergy to something that was going on, and he ended up passing. With this type of procedure, do you have to be put under? I mean, is that one of the benefits of going through this procedure versus others, is you don't have to be completely put out. You can be put maybe in twilight?
Yeah, I would say even you could take it one step further. You don't even need twilight. You can do these
Correct.
procedures with just local anesthetic only. So even somebody who's incredibly high risk for surgery, you could still do this procedure with no sedation or no twilight. And again, it can be done in somebody's experienced hands, like Misha's hands, probably done in an hour, hour and a half type of thing.
Or what's the durability of it versus
That's a great question.
conventional method?
So, I think that we have data at this point in time, long-term data. We know that it's up at 5 years, it's 80% effective, meaning that 80% of patients maintain their resolution of their symptoms, and then when it goes to 10 years, it decreases. It's a range. Some people quote that anywhere between durability between 70 to 50%. So sometimes this procedure does need to be repeated, but again, it compares well with other options. And I think that given the minimally invasiveness of it's an option for patients, and so we have those conversations. We see those patients in clinic, and they understand the alternatives, and this is an alternative many men choose.
One of the things when I just comparing it to people who have peripheral artery disease and advanced stages, CLI, critical limb ischemia. So there are quite a few doctors out there that will say, we're going to do a bypass on you because it's more durable. It'll last you 5 to 10 years versus these other minimally invasive approaches where it could be a revolving door. One of the questions that we always pose to the patient to ultimately share with their doctor is, what's the contingency plan when the more invasive procedure fails? Versus a minimally invasive approach, which there is still a contingency plan. Is that similar when it comes to PAE versus the conventional option? That is there still a contingency plan if that other procedure, the more conventional, more invasive procedure fails and it doesn't relieve symptoms? What are the options then versus using a PAE approach first?
I think oftentimes what I tell patients, sort of one of the number one benefits of doing an interventional radiology procedure like PAE or other sort of embolization procedure we do, it almost almost always doesn't take any other options off the table. And
Yes,
so,
I agree.
right? So it's a from that perspective, it's an ideal treatment because look, even if you were unhappy with it, you've not taken surgery off the table. As we know, once you sort of undergo surgery, there's no going back from that. If you have some negative side effect or complication, you may always leave yourself wondering, well, what if I did the minimally invasive option and and got benefit without this complication? Whereas this approach allows you to sort of do that, and then if it doesn't work, then you can obviously then say, okay, well, I tried everything, and now I'm going to bite the bullet and do surgery if because that the risks now make more sense
Yeah.
because I've tried everything else.
Yeah. I mean, are there urologists out there that are completely 100% against this procedure? Is that maybe one of the reasons why we're still seeing some resistance in the insurance denials? Sometimes you end up with an advisor that is more traditional to these insurance companies that are saying, do not, do not, do not, do not. Is it taking money? I hate to ask this, away from those doctors that are doing these conventional approaches and away from the hospitals?
Well, I think it's a good question to ask. Like there's, you gotta follow the money, right? Like him, so so it's smart, and I think that historically maybe there was some turf wars here, especially as this procedure was being developed and brought to the market. But urology ultimately, which is American Urology Association, took a while to approve this, right? I mean, this been approved in Europe a while back, and European Urological Association sort of completely adopted this option a long time ago, right? United States healthcare is a bit unique, and it's a pay-per-service system, and in that context, yes, there are sometimes some natural competition of who's going to do the procedure, right? And typically people who have a hammer see nails, right? That's what they see, right? But with that said, with the American Urological Association adopting this procedure and endorsing it, this is there shouldn't be any sort of urology group that is saying no to that procedure, right? Ultimately, and if anything, the trend right now, and there's IR groups out there that work collaboratively, and I think it's beautiful because what they do is they sort of optimize the right treatment for the right patient, right? They work collaboratively, they discuss it, and they end up with. And that's how we work here also. We talk to our urology friends, right? Like, and then we sort of tailor the treatment because not every patient, needs the same procedure, right? Someone with very small prostate or someone who has severe blockage of their arteries that may not allow us to access them may be candidate for something else. If their prostate is too small, but they're still symptomatic, there's other options out there, right? So, we need to work together. And we do, with urology to get the best sort of treatments for our patients.
We appreciate everything you're doing to try and advance care for patients, here in the United States, but also across the globe. So thank you so much for joining us.
Thank you, Kym.
Awesome. Thank you. So we're done with the live stream. He just popped
Perfect.
off sooner.
Yeah.
So Kym was just asking, is there a reason for a man to get this procedure if all he's doing is having more bathroom trips?
Well, I mean, we graded. There is such thing called IPSS, which is International Prostate Severity Score, which is basically sort of divides patients based on their symptoms on mild, moderate, or severe symptoms. And we graded based on urgency, which is quick sort of urgent need to go to the bathroom, frequency, how often they go, ability to initiate urination, ability to go pee, or versus wanting to pee but not able to pee, incompletely emptying the bladder and waking up at night. So ultimately how it affects their quality of life and their urologic sort of symptoms. And if they grade moderate to severe, at that point in time, pharmacologic options don't necessarily do well there, right? For patients with more advanced symptoms of lower urinary tract symptoms, just medication alone will not solve it. on top of the fact that many men just don't like or don't tolerate the side effects of some of those medications. So, for these people who are suffering, right, and they know, the men who are suffering, they typically know that they have those things. Maybe they're in somewhat of a denial. They may be like okay, well, it's normal and a part of aging, waking up at night 3 or 4 times and going to pee. But it affects them, and there are options out there that, including PAE, that are effective in taking away the symptoms and improving their quality of life.
Thank you. We appreciate you. I won't keep you more on this lovely
Thank you.
Saturday. So
Thank
good
you.
discussion. We have to, let you go and enjoy.
Sure.
And
Thank you,
appreciate it.
Kym.